Thank you very much, and thank you to the organisers for including this talk in what's been a really great meeting so far. So I'm presenting on behalf of a huge consortium. I've got no declarations to declare, but thank you, Chair, for recognising this manuscript is currently undergoing peer review, and I'm aware that some of the reviewers may be in the audience, so feel free to ask me some tough questions if it's going to help you write your review. So Mel Heitman, my close colleague and friend, this morning introduced the Stimulate ICP trial. I'm the lead for Work Package 2, Nested Drug Trial, which is in the middle here. There is a pointer, just that bit there. And that's what I'm talking about today. I'm not going to talk about the rest of the trial. So within the drug trial, this was a pragmatic, multi-site, open-label, randomised controlled trial across 12 UK long COVID clinics. Inclusion criteria were clinician-based diagnosis of long COVID in secondary or tertiary care. We randomised participants 1:1:1 to the following regime: Rivaroxaban 10 milligrams OD, Colchicine 500 micrograms BD, or Famotidine 40 milligrams OD with Loratadine 10 milligrams OD, compared to usual care, the no-drug arm. I don't have time within this presentation to go into the rationale for these drug selections, but I want to remind everyone that we were designing this trial in 2021, and so we had very emerging data at that time to support the recommendation to include these interventions. The primary outcome score, as discussed by Mel this morning, is the fatigue assessment scale or score at the FAS at 12 weeks. Secondary outcome data which we've currently analysed and are including in the presentation today at the EQ5D visual analog scale. Our power calculation originally estimated that the FAS, we see a clinically significant, meaningful difference of 10% change, and that's well validated in other respiratory diseases, which is one of the reasons for selecting the FAS. And our power calculation estimated that a change of 3 points or more would give us a statistically significant, meaningful change that was beneficial to patients, and we estimated that we need 200 participants per arm to see that change. I'm going to show you a little bit of our background data from our usual care database to support the selection of fatigue as a primary outcome measure, because I'm sure you can appreciate that in 2021, selecting the right primary outcome measure for a trial of this size was extremely challenging. So we've got a very large clinic in London where we use EPIC, and we've been prospectively collecting data, including FAS, on our participants routinely, and our trial, not just trial participants, but all of our patients who come through the clinic. We've now treated over 7,000. This is an analysis of 5,000 patients from the UCLH clinic. And going through our systematic tool where we collect symptom data at every single visit, we're able to look at associations between symptoms and factors on presentation and recovery or non-recovery. Here we're defining recovery as a self-report of greater than 75% of your pre-COVID best health. So when patients get to that point, we know clinically that they're on a recovery trajectory, and that at that point we usually discharge them with something called a PIFU, a patient-initiated follow-up, which means they stay on the books for 12 months, and they can come back if they need to, but otherwise they've got enough to get on with their lives. So in terms of factors that are associated with recovery in our clinic cohort, vaccine, either pre or post the onset of long COVID, strongly associated with a recovery. But it won't surprise this audience to hear that the factors that are associated with non-recovery, the strongest predictor was fatigue, followed by postural symptoms and myalgia. When we track our patients longitudinally over time, we see the people with the highest FAS scores are the ones who do not achieve recovery over 2 years. And we were seeing this even in 2021, so we were very clear that these are the patients with the severe fatigue we needed to target in the trial. Throughout the course of the trial, we did have to make some protocol changes. It's an extremely dynamic environment in the UK, introduction of vaccination, new variants coming through, clinic model changing. But also, we originally designed the drug trial to be nested within our cluster trial, which Mel described so elegantly this morning. But that meant the restricted eligibility to drug trial participants to those new referrals coming in through that pathway. And by 2023, our drug trial recruitment was way below target. And our existing patients were very cross with us nationally across all trial sites that they couldn't be included in the trial, that they weren't eligible when they really wanted entry into the drug trial. So in 2023, we made a protocol change. We opened 6 new drug-only sites, and we expanded the eligibility to the trial to include treatment-experienced patients, not just new referrals. This meant we had to update our analysis model, and we then had to control for cluster allocation within the original cluster trial because half of the participants did not go through that cluster trial. We had to also adjust for time since symptom onset because our treatment experienced patients had had significantly longer duration of long COVID compared to the new referrals. And that meant we also had to control for the prior management that they may or may not have had. You can see this is getting complicated. And we had to then generate time-matched usual care comparator for the drug arms because we didn't want to include a usual care comparator who'd come through the new cluster trial, a new referral, with someone who'd been in the clinic for 2 years. So this required a lot of additional statistical modeling. So we updated our multi-level model for the primary outcome measure, and we included as fixed effects, gender and treatment arm, and clinic, which meant whether you were really in a cluster randomized trial or not, as an additional element as a random effect. So we screened 7,000 patients overall, 4,000 were newly referred, nearly 3,000 were previously treated. Overall, we recruited 778 patients into the trial and assigned between 193 and 197 across the 4 trial arms. Overall, this was like many other long COVID studies. It's a predominantly female cohort of middle age, but were equally distributed across all arms of the trial. In terms of the long COVID symptoms, the median FAS at baseline ranged between 36 to 37.5, which is consistent with high burden of physical and cognitive fatigue. The long COVID symptom duration was approximately 2 to 3 years, and the median number of long COVID symptoms reported by the participants was 9. So overall, here are the headline results. We saw an overall reduction of greater than 10% in the FAS across all arms of the trial, including the usual care comparators. But we did see a statistically significant further reduction of 1.5 points in the FAS scale in recipients of Famotidine-Loratadine and Colchicine, but not Rivaroxaban. When we looked at the EQ5D, the quality of life scale, all drug recipients reported at 3 months improved fatigue, improved quality of life over the usual care arm. But again, like the drug trial, this reverted back to the baseline in the usual care arm after drug cessation. So there was an impact of these drugs on quality of life and on fatigue, but when the drug was withdrawn at 3 months and we followed up to 6 months, we saw that effect revert back to the baseline. In terms of adverse effects, these were uncommon, and median adverse effect of 1 reported per participant, but they were skewed, and unsurprisingly, recipients of colchicine had an increased burden of diarrheal and GI upset, and recipients of Rivaroxaban reported increasing bleeding events, predominantly menorrhagia. Then we asked the question, did the length of fatigue alter drug efficacy at 12 weeks? And this is really interesting. So when we didn't adjust for the symptom length, we saw the trial results as I presented earlier. But when we adjusted for symptom length, the increased efficacy was seen in the colchicine arm. So people with longer symptoms experienced a greater reduction in fatigue when they'd had longer symptoms than those who had shorter symptoms in recipients of colchicine. And that increased the statistical effect. So in conclusion, fatigue fell unexpectedly in all arms, and I have to stress that we did not predict this effect of usual care at the start of the trial. This was not a trial where patients got cuddled and looked after and had a specialist nurse. This was a, here you are, you're in a clinic, oh, you want to be in a trial? Great. Come up, sign up, give us some blood, here's a drug, off you go, we'll call you in 3 months. Okay, it was not a really friendly trial, so we didn't expect people to feel better as part of the trial itself. But it goes to show that all components of the trial, including the usual care arm, are really important for patients, and you can't disaggregate usual care from a drug arm, and it's really important to control. And as Mel and I go forward to design the next drug trial, we're really thinking hard about how to understand better what components of usual care improve fatigue, and how do we manage that and control for that in future drug trials. The drugs overall were well tolerated. Both colchicine and famotidine with loratadine additionally improved fatigue over usual care, but those drug effects reverted on withdrawal. The mechanism of this is unknown. Low-dose Rivaroxaban did not improve fatigue over usual care. All drugs additionally improved quality of life at 12, but not 24 weeks. So this is a huge team, of which was led by Mel, who you heard from this morning, and Ami Banerjee, and her acknowledgement slide is the same as mine, an incredibly important team, but I'd like to particularly acknowledge our project manager, Sarah Clegg from UCL, our colleagues at UCLH, and also our colleagues at the University of Central Lancashire, who all managed the trial. It instead looks like this, a bunch of smiley people who actually all got on remarkably well and worked in incredibly challenging circumstances and gave up a lot of holiday time, particularly to run and lead this trial. And I'm going to leave you with a picture of our PPIE panel, because I have to acknowledge all our patients, all our participants who gave their time, blood, and willingness to, and energy into being enrolled in this trial, and the incredible support that we've had from them throughout. Thank you for listening, and here's a QR code to scan to read more about the trial and many of our outputs. Thank you.